Good morning, one and all. Today I am going to present case presentation on rheumatogenic retinal detachment. A 50 years old male presented with sudden painless loss of vision in right eye since 2 months, which is associated with floaters and photopsia in right eye. They are floaters in left eye since 6 months. There is no history of trauma. There is no history of usage of any drugs. In past history, patient has history of hypertension and diabetic since 2 years and he is on medications. He is taking mixed diet, but there are no addictions. Family history is unremarkable for similar complaints. On general evaluation, his blood pressure is slightly raised. Rest all evaluation is within normal limit. On ophthalmic evaluation, his right eye vision is PL accurate with PR inaccurate. And in left eye, vision, best corrected visual acuity with plus 0.5 spherical is 6/6. And IOP with rebound tonometry is 10 and 18 millimeters of mercury. On slit lamp evaluation, rest anterior segment evaluation is within normal limit apart from RAPD in right eye. On fundus evaluation, both eyes, media is clear with normal size of the disc, normal shape of the disc with cup disc ratio of 0.3:1. And there is temporal quadrant of right eye, rheumatogenic retinal detachment with lattices and horseshoe-shaped tears are present. And in left eye, there are multiple lattices with hole in lattices, indicating myopic lattice degeneration. These are the similar fundus images showing multiple pigmented lattices with horseshoe-shaped tears in right eye. And they are initially when we examined his left eye, posterior pole appeared absolutely normal. But when we checked the periphery, there are multiple pigmented lattices with holes in the lattice, indicating myopic lattice degeneration. He was routinely investigated for all blood investigations and he was sent for medicine fitness in view of diabetic and hypertension. And he was planned for right eye under local anesthesia, right eye vitrectomy with endo laser and silicone oil, and left eye under topical anesthesia. He was planned for laser for sealing of the lattices. And post-operative day 1, his retina appears attached with lasered HST and lattice with silicone oil, and in left eye there are lasered lattices with double frequency and diag laser. In post-operative 1 week, best corrected visual acuity improved from PL positive with PR inaccurate to counting fingers half meter, and there are silicone oil reflex seen with attached retina. And post-operative picture, after removal of silicone oil 4 months, his best corrected visual acuity is improving only to 2 meters, but the retina is attached. Then when we evaluated, he has cataract with NS3 grade with PSC, posterior subcapsular cataract. And in right eye, there is hazy view. We can see the attached retina with laser lattices. Best corrected visual acuity in left eye is 6/6 with plus 0.5 diopter sphere, and he has NS1 cataract with PSC. This is the left eye laser lattice picture. When coming to review of literature, there is like if the retinal detachment is involving multiple planes, then pars plana vitrectomy has more anatomical success when compared to scleral buckling. And in patients who developed cataract after vitrectomy, there is increased chances of nuclear drop events occurring. So we prefer minimal incision cataract surgery when compared to phacoemulsification. So there should be vigilant ocular evaluation in patients having risk for retinal pathologies. And if there is retinal detachment in one eye, then thorough evaluation of periphery of other eye should be done, and patient should be counseled for regular follow-up. And retinal pathologies, patient should be explained about the prognosis and post-operative positioning, and challenges should be during cataract surgery in post-vitrectomized eyes should be kept in mind. These are my references. Thank you.
I think it's a very good presentation and lots of learning in this case. Dr. Meghana, you said the PR was inaccurate in this patient in the beginning.
Yes, ma'am.
So what are the, can you just explain why the PR was inaccurate? Projection of rays, because there is PVR and subretinal folds you didn't show, because it shows that it is probably a very old retinal detachment.
Yes, ma'am.
So, what were the positive points in your case for projection of rays being inaccurate in the
Because
beginning?
there are more quadrants of retina being involved. In those quadrants, there is inaccurate PR, ma'am. Projection of
No,
rays.
but a fresh retinal detachment will not have inaccurate PR. This we need to learn. It will only be an old retinal detachment which will give you a projection of rays which are inaccurate.
This case is subacute presentation, ma'am. It is not acute, it is not chronic also, ma'am. When he presented, it is like 2 months old
So that could be
duration.
the reason of not improving vision after the cataract surgery as well after that. All right. Any further points, Dr. Ankur, Dr. Shishir?
So usually in a case of detachment, the PR should be accurate. I mean, it's only like if it's a very old detachment or there's a giant retinal tear, the retinal flap is not there. So sometimes there might be an inaccurate PR, and after surgery it returns back. So this case would not explain an inaccurate PR actually, as Madam said. So this needs to be explained further. And so what was the surgery exactly done in this case?
In him, we have done right eye vitrectomy with endo laser of the sealing of these breaks, and we have put silicone oil, sir.
And silicone oil was removed later on?
Yes, sir. After 4 months, silicone oil was removed, sir.
And the cataract surgery was done?
No, sir. We are following him up for doing cataract surgery, sir.
Right. So
We
so
have
when-
planned him
So
this
many
month.
times when cataract is there, so maybe the two can be combined at some point. of time.
Initially, he don't have cataract, sir.
Correct. So when oil is removed, so maybe cataract can be done as well if it is significant.